Hi, everyone, and welcome to the session, How the Pandemic Affects Cancer Care. I want to get started right away, just so we have as much time for questions as possible. So Dr. Hirte's full bio can be found by clicking on the speakers tab, but I will just mention now that Dr. Hirte is a medical oncologist at the Juravinski Cancer Center in Hamilton, Ontario. He is an associate professor in the Department of Oncology and at McMaster University with a cross appointment in the Department of Obstetrics and Gynecology. So Dr. Hirte, thank you so much for joining us on a Saturday to share your insights on this really important topic about how the COVID-19 pandemic is affecting cancer care. And I am going to send it over to you. And then at the end, hopefully we will have time for questions. So again, if people can just put their questions in the chat box, we'll make sure that Dr. Hirte sees those at the end. So over to you, Dr. Hirte.
Great. Thank you, Kaylee, for that introduction. And thank you to Ovarian Cancer Canada for allowing me the opportunity to take part in this breakout session. So what I would like to do, good afternoon to all of those you in Eastern Canada, and good morning to those of you out West. So what I'd like to do is just give a brief overview of kind of what my perspective of how the pandemic has affected cancer care, and how you can manage that in terms of your visits, and just to give you some pointers. And I hope to do that in about 10 minutes, leaving lots of room for questions and discussion. So please have your questions ready. I'm just going to share my screen. And Kaylee, has that come up?
Yep.
Yeah, okay. So let me just go on to the first slide. So the learning objectives are really lifted from the flyer. So it's really going over how things have changed with the pandemic, and to try and help you get the most out of your virtual visits, and some practical advice in terms of how you can be your advocate in the new normal. So here are my disclosures. And in terms of what I'd like to cover, so I'd like to give you an overview of how I think the pandemic has affected healthcare, and particularly cancer care in Canada, how medical appointments can be set up to minimize exposure, should your visits be face-to-face or virtual, how best to prepare for your face-to-face clinic visits, and also what you can do to get the most out of visits when they're virtual. I want to talk a little bit about COVID-19 vaccinations and boosters, and then summarize and then leave some time for questions and discussion. So let's talk a little bit about COVID-19 and its effects on healthcare. So this is data. The next few sets of slides are from the CIHI Data Institute that have looked at the Canadian perspective. So really, right after the pandemic started, there was a big drop in face-to-face visits. Over 52% of visits in the month following the outbreak were virtual, and emergency visits dropped considerably the following month by over 50%. So big change now we did. And you can see over time what happened to face-to-face versus virtual. So in February, where we were still doing things normally, that was kind of the baseline, but you can see very rapidly virtual visits became about 50% of the total visits. And although we are getting back to a normal number of out of total visits, we still have a significant number and percentage of visits that are occurring virtually. And certainly in the fall at my center, about 25% of visits were still virtual as opposed to face-to-face. And there are big changes in visits to the emergency department. You can see once the pandemic hit, emergency visits dropped by over 50% in the following month. If you looked at hospital admissions and surgeries, and usually our hospital beds are, we're usually at or close to 100% capacity. So any kind of a drop is a huge change in what we're normally used to. So you can see in terms of inpatient occupancy, the month after things started, we were down, 40% of our beds were open. We've never seen that. And although it is creeping back to normal, in fact, last month we're again at or over 100%. It took a long time for that to recover. And more importantly, from the cancer perspective as well, big drops in surgeries. So the month following, 80% reduction in surgeries. We are creeping back to normal, but there's a huge backlog, as I'll talk about in a moment. There's considerable catching up to do. And in terms of those surgeries, most of the canceled surgeries were for more minor things, things like vasectomies and tonsillectomies and cataract repairs. But you can see even cancer patients, there was a 20% reduction in the cases that would normally have taken place. And this has obviously had a big effect in terms of getting a diagnosis and getting treatment started. We don't know yet what the effect of this is going to be on outcomes. It's too early, but clearly it is a concern that, are patients presenting with more advanced disease? Are they having to wait longer to get their surgery? And so how does it affect cancer patients, and in particular patients with ovarian cancer? Well, clearly we've had delayed treatments due to closure and reduction in volumes and facilities. We've had canceled surgeries. Patients had to get their COVID testing done before they had their surgery, and that often delayed things by a number of days. There were delayed diagnoses due to cancellation of appointments, changes in facility hours, and reduced follow-up appointments, and alternate changes in management. So in diseases where we could give oral treatments, we often switch them from IV to oral so they wouldn't have to have a direct visit at the center. We had more virtual monitoring as opposed to face-to-face, and that has its downside as well, as we'll talk about in a moment. And then there's the whole quality of life issues. Clearly, patients who were admitted to hospital couldn't have their family visit or had that considerably reduced. And there was all the anxiety that all of this caused with the delays. So high level of anxiety and depression as a result of all of this. And how did COVID affect your clinic visits? Well, big changes there as well. So certainly, when you're not having a face-to-face visit, there were visits done by telemedicine and virtually. Those patients who were coming to the clinic often had their blood drawn and injections done outside of the clinic rather than having multiple visits. When you come to the cancer centers, there are questionnaires before you come in. You have your temperature checked. You have to come in with your mask, and you have to socially distance. So lots of changes, and many of those things are still occurring in terms of just monitoring for COVID as people come and go from the cancer centers. So given all of these things, how can your appointments be set up to minimize your exposure to COVID? So, and the issue is, which appointments need to be face-to-face and which can be virtual. Certainly initial visits and those visits that you require an assessment to see how the treatment is going or to assess side effects or symptoms, I think those clearly should be face-to-face. Visits during ongoing treatment, and if you're having well follow-up visits, those can often be done virtually. But I think certainly intermittently, one still needs to have a face-to-face visit. And these virtual visits can happen either by telephone or via a virtual interaction, either Zoom or Teams or WebEx or OTN. There are a variety of potential mechanisms to that. And I'd appreciate feedback during our question and answer in terms of which formats you think work best for you, and what suggestions you might have in terms of how we might make those visits better. So how do you prepare for your face-to-face clinic visits? Well, it's important to get your vaccine, and we'll go over vaccine strategies in just a moment. And keep your distance when you're at the center. Wear your mask, and make sure you wash your hands before and after your clinic visit. So what can you do to get the most out of your virtual visit? Well, so certainly it's important that you make a list of things that you want to discuss at the visit. You should have a list of your medications and any changes in them since your last visit. And ideally have those medications really at hand, so you can see how many refills and things that you still have on board. And let your physician know if you require any renewals of your prescriptions. Are you having any new symptoms? And if so, make a list of those. If you're on active treatment, make a list of any side effects since your last visit. And if you've had lab tests or imaging, make a list of the ones that you need to go over and discuss with your physician. And lastly, and one of my favorites, do you have any insurance forms you need to fill? We love to fill those out. So make sure you let us know if you have any of those that need to be taken care of. All right, so let's talk a little bit about COVID-19 prevention. And so this is a very interesting graphic that I thought really related well to what we're trying to achieve. And it's called the Swiss cheese respiratory virus pandemic defense. And basically it says that, we have a number of potential interventions that we have at hand, but none of them are perfect. So each intervention is a layer and the imperfections are the holes. But ideally, if you put a number of these slices together, the slices hopefully will block all the holes at some point in time. And so having multiple layers improves success. And there are two sets of responsibilities. There are the personal responsibilities that you have, and then there's the shared societal and organizational responsibilities. And you can see those range from the personal responsibilities, physical distancing, stay home if you're sick, wearing your mask, good hand hygiene and cough etiquette, avoid touching your face. If you're in a crowded place, limit your time. And then the shared responsibilities, access to testing for people who are symptomatic, who have been exposed, good ventilation wherever you're at, or having good filtration and being outdoors wherever you can, government messaging and financial support, and then quarantining and isolation. And lastly, the vaccine strategy. And let me talk a little bit about those. So I hope you're all in favor of COVID vaccines and can raise your arm. The recommendations about COVID vaccination can be found at this website. And I don't know, Kaylee, if you're going to share the slide sets, but that's the link there that goes over many of the recommendations I'm going to talk about in a minute. And vaccines are, and this is just an example of the success of other vaccines. And you can see these are really the common viral infections that we've had successful vaccines for. And we've really eradicated many of those, not completely. Smallpox, in fact, has been eliminated, but many of these other viruses are around, but they've been prevented from becoming problematic because there's been fairly uniform vaccination, and they are extremely effective in not only preventing cases, but preventing deaths from these illnesses. But as we've seen with measles, if we let our guard down and people don't get vaccinated, these diseases are still around and can still cause problems, infections, and potentially death. So, so getting vaccinations is a very important health strategy, and certainly has had a huge effect on overall health of the general population. And I think vaccines are a really neat approach, because they're really tricking your body into thinking that it's been infected without having the downsides of actually having an infection. So I think it's a brilliant, personally, I think it's a brilliant strategy. So what about COVID vaccines? So they are highly effective. And this is data from the European vaccination group collected over the past year. Clearly, the mRNA vaccines, the Pfizer, BioNTech, and the Moderna are the most effective, and those are the ones we'd certainly recommend. So they're 95% effective in preventing getting COVID, and close to 99% effective in terms of preventing hospitalizations and death. And they're the 2-dose regimen. They do have side effects, and certainly the common side effects that we've seen with these vaccines are local effects such as soreness at the injection site, some fatigue, headaches, flu-like symptoms, chills. But all the other more serious side effects are really very uncommon. You can see they're all kind of less than 1%. And in fact, over 40% of people who had vaccinations had no side effects at all. So highly effective and really fairly low side effects, and certainly severe side effects are extremely uncommon. So the question that many of you may have is, well, if you've had your 2 shots, who should get a third booster dose? So residents of long-term care facilities and retirement homes, and people over age 70, and those who are immunocompromised should get a third dose. With respect to you folks, people who are on active treatment, so getting chemotherapy or targeted therapies or immunotherapies should get a third dose. Those people who have finished their chemotherapy, there are not recommendations to get the third dose unless you meet the other criteria. And also the people who are looking after you, the healthcare workers, if they've received their second dose more than 6 months ago, should get the booster dose as well. And the recommendation is to get either the Moderna or Pfizer booster dose, regardless of which previous COVID-19 vaccine you've had. And again, there's the link to the website that tells you which medications, in terms of being at higher risk of being immunosuppressed, would be ones that should be issues for people requiring a third booster dose. So let me finish up my presentation here with just some summary and conclusions. So certainly the pandemic has affected access to and delivery of cancer care. Cancer care at times is more advanced due to delays in assessment and workup. Canceled surgery has resulted in a backlog of cases, and it likely will take many months or years to catch up from that. Unfortunately, clinical trials activity was drastically reduced over the past year, but it is recovering, and we are activating a number of studies again. And what we've learned from the pandemic to carry forward are the following: that we actually can increase visits that occur virtually. Blood work can be done at outside lab prior to visits, so we have that when we see you or talk to you. We've used electronic media successfully to make contact and convey information, and we've made greater use of electronic records and access to labs and imaging across various regions and across provinces as well. So I'll stop there, and I'm happy to answer any questions that you have. So I'm going to take off my screen share here.
Well, thank you so much. You've covered a lot of ground, and I really appreciate that. We do have a question here that I want to ask. This is regarding time between vaccine doses. So NACI or NACI, I never know which, are now saying the time should be 8 weeks at least between number 1 and number 2. Because of my chemo journey and recovery time and starting Lynparza, I received 1, 2, and 3 each a month apart. I'm on anti-rejection meds as well, so meet the third dose criteria easily. Any idea about what effect having them so close have on protection?
Yeah, the further they're spaced apart, the better. I mean, I guess that with respect to which vaccines you had is also a question. So if you didn't have one of the Pfizer or Moderna, and you've had one injection of the booster, I think there is a role, particularly because you're on an immunosuppressive drug, to get a second RNA vaccination. So that would be my, I guess the question is, how long ago was your third booster? So there may be a role for you, given your particular situation, for an additional second mRNA injection.
Right, and she's just added Pfizer was the first and Moderna for the second and third.
Second, yeah, and third. So I think you're probably okay for the time being, given that.
Got it. Thank you. Another question. My clinic is doing virtual visits. How can I best advocate for myself to see my gynae oncologist in person?
Yeah, so I think having intermittent face-to-face visits, as I mentioned, is really important. And certainly, I don't know whether you're still in active treatment. Certainly in active treatment, we generally see patients every second or third visit, if everything is going well. Clearly, if you're having symptoms and side effects or new things going on, then I think it is important to have a face-to-face visit so they can examine you and really get a good sense of what's changed, if there are new symptoms. But certainly even in well follow-up, I think intermittently you should have a face-to-face visit. So I would really push to say I really need to see you and want to see you face-to-face intermittently, not for all of them, but certainly at reasonable intervals.
And I guess, and I don't see any other questions, so do feel free to ask more questions, or as Dr. Hirte asked at the beginning of the session, if you have thoughts on how your virtual visits have gone, or tips in terms of for the physicians in terms of how to make those easier or better, please feel free to include those. And I'm
Yeah, and
curious
I'd be interested just to see, what platforms people have used, and how comfortable they are with that, how well that's worked. What could we do better with those? And we've tended to use at our center either the Zoom platform or the OTN, Ontario Telenetwork. The Ontario Telenetwork is really pretty finicky, so we haven't used that as much. Zoom seems to be a lot more user friendly, but I'd appreciate people's thoughts in terms of what they thought worked well in those situations.
Well, I know that as we wait for maybe some of that feedback to come in, I know that I've heard back from women who, and it's really mixed. I mean, some women are saying, look, I actually appreciate having some virtual visits because I don't have to drive so far. I don't have to actually come into the hospital. Yeah. So they actually appreciate it. And others, I think, I mean, we were talking about this a bit before the session started, but there is a lot of anxiety when somebody comes to the end of that first line of treatment. And now it's just a waiting game, and they're used to going into the cancer center, getting treatment fairly regularly, being seen physically by their healthcare team. And all of us, even before COVID, it's that sense of all of a sudden I'm on this iceberg now floating off and no one's seeing me anymore. So I can't imagine how that anxiety has been exacerbated by these virtual visits and just not feeling like someone is there kind of looking out for me. And I don't know, you talked about this briefly, but are there tips for people going through this to say this is when you really should be insisting on an in-person visit, or these are the things to be looking out for, and any more thoughts on that, because it is such a time of anxiety.
Yeah, so certainly if you are getting symptoms that are suspicious of something coming back, so change in bowel or bladder function or bloating or things, discomfort that's just not settling down after a couple of weeks, those are things that really are flags that should require a face-to-face visit. Certainly you need to continue to be followed regularly, and we usually use my algorithm is the first year we do it every 3 years, so every 3 months for the first year, every 4 months for the second year, 6 monthly out to 5 years, and at 5 years you're graduated back to your family doctor. But certainly for those regular follow-up visits, you still should have I generally do routine CA-125 levels because they're really helpful in terms of picking up things earlier. Those probably should, because of variability in terms of the test kits that are used in the private labs, we usually have the patients at least come to the cancer clinic lab to have those done regularly. And generally we have probably do alternate, at this point, doing alternate virtual versus face-to-face visits in those follow-up periods of time. But clearly, if there are symptoms that develop before a visit, then a virtual visit should be changed to a face-to-face. And if there are problems in between, then we have to make arrangements to have you come in for a face-to-face visit if there are concerns about new symptoms that really are going to require an examination and really seeing it face-to-face to help sort that out.
Got it. We have someone else has added some system needed to facilitate Zoom platform or visual anyway. My clinics have only done virtual phone, and that's frustrating. Virtual is okay at times, but need a visual. I'm in Halifax, QE2 facilities. Don't know why they don't do visuals. My clinics have always been able to do mostly face-to-face, fortunately. So sounds like things are still face-to-face, but.
And I agree, it is helpful to kind of see, and there's a lot of information you get by seeing how somebody's reacting and their level of anxiety, and all of those things will help, seeing somebody face to face. And it's a better way to bond with the person you're talking with, for sure. So, it is a little bit, it does take a little bit more in terms of setting things up, but the technology is there. Anybody who has a laptop or a smartphone, it's pretty straightforward. And Zoom is really very user friendly. And it sounds like you've used Zoom, and that's what we tend to use too. So I think it's not hard as long as you've got a smartphone or a laptop or tablet at your end, and it really doesn't take any longer than a phone call. And I actually prefer that format as well. So I agree with you. So you might want to let your folks at your center know, and perhaps you can gather a group of other of patients as well who that might influence people to do the video conferencing more frequently.
I think especially for, I know I was meeting with some people last night at the meet and greet, and we have a lot of folks who have been recently diagnosed. And I think it's one thing if you've developed a relationship. I know patients of yours, Hal, who have known you for years, and they, picking up the phone, there's a lot of shortcuts you can do because you've already established the trust and the relationship. But for people just starting out, for both the physician and for the patient, at least even in a workspace, Zoom and face-to-face, you can just make those nonverbal connections and get to know each other just a little bit better. So that makes a lot of sense.
I agree completely. Yeah, for sure.
Well, this brings us to the end of the questions that we have here today. So I really want to thank you. The session has been recorded. I know we have breakouts going on, so I know that others are going to be watching this video later as well. So I really appreciate your time today. I know you have a wedding to get to, so so we're going to let you go. And thanks again for all the information. That's great to see it all gathered. It's very hard to gather some of those statistics. So I was really interested just to see some of the impact in terms of the numbers, and also get your advice on the emotional impact as well, and how to perhaps feel a little less anxious in terms of making those connections with your physician.
Thank you for that. And thanks everybody for joining the session. Have a good afternoon, and enjoy the rest of the sessions.
All right. Take care.
Bye-bye.
Bye.